Welcome to this medicine masterclass in which we will be discussing chronic liver disease and liver failure. Liver failure or hepatic insufficiency is the inability of the liver to perform its normal synthetic and metabolic functions as part of normal physiology. Symptoms include fever, malaise, anorexia, weight loss, right upper quadrant pain that can occur due to liver stretch, and then ascites and fluid overload. Let's take a case. Mr. Jones presents with abdominal distension. Let's talk through the features that we would expect on an abdominal examination consistent with liver disease. On inspection of the abdomen, the patient may appear comfortable with signs of generalized bruising, cachexia, pallor, and signs of excoriation. But the key finding is that the patient has a distended abdomen with visible caput medusae and spider nevi. On palpation, the patient may have hepatomegaly, and this would be evidenced by a smooth or nodular mass in the right upper quadrant which moves inferiorly on inspiration towards the right iliac fossa. Percussion of this mass would be dull, and you'd quantify how many finger breadths below the costal margin you're able to palpate this mass. More than 2 finger breadths is considered abnormal and suggests hepatomegaly, and you would comment that you were unable to get above the mass. If ascites is present, on percussion you would notice shifting dullness. This is where the patient is percussed from the midline of the abdomen, where the note would be expected to be resonant. Where dullness is present, at that point the patient is turned onto their side, and after about 30 seconds percussion is repeated, and if that dullness changes to resonant, that suggests that the fluid has shifted, confirming the presence of ascites. Ascites, by definition, is a pathological accumulation of fluid in the peritoneal cavity. Now, patients will report progressive abdominal distension that can be painless or associated with abdominal discomfort. As the ascites progresses and causes diaphragmatic splinting, the patient may also report shortness of breath. Patients with cirrhosis may have other symptoms related to hepatic decompensation, such as confusion or advanced symptoms such as GI bleeding. The mechanism of ascites is a combination of liver failure and portal hypertension. As the liver fails and the liver synthetic function decreases, albumin production also decreases, and that reduces the oncotic pressure, and so fluid seeps out of vessels. Liver failure decreases renal blood flow, and that's because the waste products cause vasodilatation, redirecting blood flow away from the kidneys. Hypoperfusion of the kidneys stimulates the juxtaglomerular apparatus, activating the renin-angiotensin-aldosterone system, which causes increased salt and fluid retention, which exacerbates ascites. Ascites can be graded as grade 1, 2, and 3. 1 is mild ascites detectable only by ultrasound. Grade 2 is moderate ascites manifested by moderate symmetrical distension of the abdomen. And grade 3 is large or gross ascites marked with abdominal distension. On auscultation of the abdomen, you would expect to find normal bowel sounds, but when you auscultate over a failing liver, you may hear a hepatic bruit suggestive of portal hypertension. As well as evidence from the abdomen suggestive of chronic liver disease, find peripheral evidence to support your diagnosis. There are a number of signs in the hands. For example, clubbing is associated with chronic liver disease, as is leukonychia. Leukonychia is a white deposition in the nails, and that's associated with hypoalbuminemia, suggestive of decreased synthetic liver function. Terry's nails, which are proximally pale and distally darker, are also associated with liver disease. The patient may have palmar erythema. That's a reddening of the palms over the thenar and hypothenar eminence. This may also be seen in the soles and is associated with normal physiology such as pregnancy, but also chronic liver disease. Dupuytren's contracture involves a thickening of the palmar fascia, resulting in the development of cords, leading to flexion deformities of the fingers or the thumbs. Bruising may suggest that the clotting factors are not being produced by the liver, resulting in coagulopathy. Asterixis and negative myoclonus, or a hepatic flap, can occur due to the buildup of ammonia due to liver disease. Apart from the hands, gather evidence from the face. The patient may have scleral icterus, which is jaundice sclera due to hepatic failure, or if the etiology is Wilson's disease, they may have Kaiser-Fleischer rings. This is a green-yellow discoloration at the corneal margin. On the chest, look for spider nevi, central red spots with reddish extensions. More than 5 is significant. The patient may have gynecomastia or loss of hair over the chest. In a male, this is indicative of pseudo-feminization occurring as a result of the inability of the liver to metabolize estrogen. Examine the legs, looking for pitting edema. This may occur due to hypoalbuminemia, resulting in loss of oncotic pressure and extravasation of fluid. Putting all this together, you're able to present a differential diagnosis of liver failure, and then you need to work out the etiology. In a young patient with no signs of chronic liver disease, think about drug overdose such as paracetamol. In a patient with chronic signs, as the ones discussed previously, think about alcoholic liver disease and other chronic conditions such as autoimmune hepatitis, primary biliary cirrhosis, and primary sclerosing cholangitis. So present your case succinctly. Mr. Jones is a Caucasian man presenting with shortness of breath. He was comfortable at rest, and I believe the gentleman has signs consistent with liver failure. On examination, the patient appears comfortable at rest with generalized bruising, cachexia and pallor. The patient appears jaundiced with a distended abdomen. There are visible caput medusae and spider nevi as well as peripheral edema. On palpation of the abdomen, there is hepatomegaly, evidenced by a smooth or nodular mass in the right upper quadrant, which moved inferiorly on inspiration towards the right iliac fossa and is dull to percuss. This is approximately 2 to 3 finger breadths below the costal margin, and I was unable to get above the mass. I also noted shifting dullness, indicative of ascites, and auscultating. The bowel sounds were normal, but there was a presence of a hepatic bruit, suggestive of portal hypertension. The patient had other signs of chronic liver disease, including clubbing, palmar erythema, Dupuytren's contracture, and leukonychia. The pulse was regular, and there were no needle track marks along the arms. The evidence of decompensation in this patient includes jaundice, ascites, but there was no evidence of encephalopathy. So this would be a very succinct way of presenting a patient with chronic liver disease. Thank you very much for attending this medicine masterclass.